So we talked about who, we talked about what, now we'll talk about where, and that's, Tracy already brought this up, mentioned it, talking about staging. And that is, where is the cancer located? So, the formal system that we use as physicians is TNM, or the tumor within the lung, the N, or the nodal status, usually within the chest cavity, or sometimes within the lung, the cavity, the lung pleural reflection, and then metastasis to other organs. The other organs that we commonly think about for lung cancer include the other lung, liver, adrenal gland, bone, and brain. And that's why, and we'll get into the sort of staging studies that we do. So one of the problems with lung cancer is that often in early stages it is asymptomatic. So this is a sort of a rough approximation. A localized tumor is stage 1 and 2, meaning basically just a tumor without lymph nodes, stage 1, or either a larger tumor, stage 2, or lymph nodes within the lung, only represent about 20% of lung cancers. In contrast, in breast cancer, where for years they've had effective screening with mammography, I should know this, but it's much higher. It's in the range, certainly greater than 50%. I think it's probably in the 70 to 80% range are stage 1 and 2. Regional are with stage 3 is when the lymph nodes in the middle part of the chest, in the mediastinum, where we check for the mediastinoscopy or EBUS, and then metastatic is when it's spread to one of these other organs. So how do we stage? There's conceptually, the way we think about it is clinical staging and then pathologic staging, which we'll get to next. So clinical staging is basically with x-rays and scans. So we do a CT scan of the chest and the abdomen and pelvis, and like I said, we look for lumps and bumps. And PET scan, or positron emission tomography, is typically nowadays, I think 10 years ago, they used to be sort of standalone instrument. I think now all PET scans that are done in this country are basically combined with a CT scan, not as good as a diagnostic CT scan, but it's often you'll see a combined CT PET. It looks at these lumps and bumps and says, are they metabolically active? In other words, relevant to the question that I addressed a couple of minutes ago, are they taking up a lot of sugar, a lot of glucose? We'll sometimes do magnetic resonance imaging or MRI scan, typically of the brain. Sometimes we'll do it of other spots for particular specialized reasons. And then there's other scans that we'll sometimes use, but the vast majority, probably 95% of the business I do is going to be CT scan, PET scans, and MRI scans. So pathologic staging, so here, let me back up. So we talk here about clinical staging. That means, you see an x-ray and you see there's an abnormality in, for example, the adrenal gland, one of those glands in the abdomen. Well, what pathologic staging means is, well, is that really cancer, or is it something else? And why do we do that? Well, so that means basically getting a biopsy in order to prove that. Why? Well, not every lump or bump is cancer, and in fact, not every metabolically active lump or bump is cancer. And so we feel really strongly here that it's important, as long as it's safe and reasonable and feasible, to prove that a lump or a bump that looks like it's cancer is really cancer. And the rules, I have sort of two rules of thumbs, and I sort of try to beat this into and I don't beat any of our folks really, but I try to really ensure that all my colleagues, agree with this, and also my trainees, the fellows that I try to train to be oncologists, that I like to biopsy the site that would prove or maybe disprove at the most advanced stage. So, for example, it's very common to have benign growths of the adrenal gland. It turns out the adrenal gland is a very common site of metastasis from lung cancer. So how do I know the difference? Well, sometimes the radiologist can tell us it looks like cancer or it looks like a benign growth on the adrenal gland. The only way that I'm happy about that is to prove it. So I put a needle in it and prove yes, cancer, or no, not cancer. Treatment might be, terribly different from surgery to chemotherapy or radiation plus chemo. So it's really important to prove whether that more advanced stage, that M stage, the metastasis, is really a metastasis or if it's really just a benign lump. And lots of anecdotal experience where that's really made a difference between cured and not cured. And then biopsy, I think another really relevant thing is, at least for a patient that starts off as an early stage, but then looks like they've recurred or had a recurrence of their cancer, I think it's always relevant, again, if it's safe, if it's feasible, to biopsy the site of first recurrence. Sometimes we can't do that, so it's, while we sometimes do biopsies in the brain, sometimes it's not feasible to do it. So brain is, for example, one spot where it's sometimes hard, and there are other spots where it's sometimes more challenging. But as a rule of thumb, so these are the 90% of the time this is the right answer, 10% of the time you can't for a variety of reasons. So how do we stage? Again, we typically do biopsies, and it's by nature of what it is. It's invasive. So meaning that we're putting a needle into some place that normally doesn't see a needle. So it might be a CT-guided biopsy, meaning you get a small sort of a limited CAT scan, and then they see where the spot is, they mark it on you, and then they put the needle in, they go back into the CT scan, make sure the needle's in the right spot, and then they get the tissue out and examine it. It may be through a bronchoscopy. Tracy described that, where they go down into the within the lung, within these trachea, the bronchi and bronchioles, etc. Sometimes we'll do it in combination with this ultrasound technique that can help to tell them where to aim the needle, and that's particularly useful in doing biopsies of lymph nodes within the mediastinum, within that middle part of the chest. Sometimes we'll do, and you may have heard of an EGD or esophagoscopy, so we'll sometimes do that with our gastroenterologist, also with ultrasound, because there are some lymph nodes that are easy to get to with bronchoscopy, some that are very hard to get to with bronchoscopy, but it turns out the EGD can access those. So we'll increasingly using that. Like as Tracy mentioned, we'll do mediastinoscopy, often just the same day procedure, and go home that afternoon. And occasionally we'll even put patients through a surgery. So, for example, a small limited surgical procedure in the lung to prove that a spot is cancer or not. The most common scenario for this might be a ex-smoker who has a big nodule on one side of the lung and then a small one on the other side of the lung. I might say, well, do we really know that? And we've got a biopsy of the one side. So, for example, on the right side, a big 3-inch mass, and we biopsied it and it's cancer, but the other side is too small to do it with a CT-guided biopsy. And I might say, well, if that's not cancer, then maybe it's an early stage cancer on the right side. So we'll even put patients through a procedure to do a surgery on the opposite side to make sure that that's cancer or not.